Hi everyone, my name is Kaylee Savage. I'm a second-year internal medicine resident at Creighton University, and the case I'll be presenting tonight is called Pachymeningeal enhancement in intravascular large B-cell lymphoma, elusive MRI findings in an already rare disease. So I'll give you the clinical background and the objective findings and then kind of run through our hospital course, which may highlight our learning points the best. So we had a previously independent 61-year-old male with very minimal past medical history, and he had just returned from a 3-month trip to Mexico to visit family. At that time, he was having fairly nonspecific symptoms, including poor appetite, some mild GI symptoms. He first presented to his PCP with symptoms including headaches, vision changes, and arthralgias, for which his PCP was understandably concerned for GCA. He was started on high-dose steroids and sent to a rheumatologist and an ophthalmologist. By the time he presented to his first acute care setting, this was an emergency room in rural Nebraska, and this was roughly 9 weeks after returning from the United States. His symptoms at this time included night sweats, cyclic fevers, headaches, blurry vision, neck pain, poor appetite, generalized weakness, and dry mouth. They did an MRI at this facility, which showed bilateral meningeal enhancement. They did an LP, which was read as hemorrhagic, and then his inflammatory markers are as follows, as well as his leukocytosis, mild anemia, mild hyponatremia. This was when he was transferred to our hospital for further workup. So his review systems, again, largely nonspecific: chills, poor appetite, fever, night sweats. He did report some blurry vision, a dry cough, lots of stiffness and weakness, some diffuse abdominal aching, headaches, and hives. On physical exam, his vital signs were largely unremarkable. Most notably, he was very ill appearing, very exhausted. He had photophobia, poor pupillary constriction, notably negative Koenigs-Brzezinski's test. Cardiovascular and pulmonary exams were unremarkable. He had some mild abdominal distension, and then the previously mentioned hives on his skin. But notably, neuroexam was very non-localized with no focal findings. Lab-wise, we dove into an infectious workup and really ordered a whole lot of the exotic travel-related infectious labs. We found out his EBV IgG was positive, his dengue fever IgG was positive, but these seems to be red herrings. We did echoes looking for IE, which were negative. We began a rheumatologic and an endocrine workup, largely negative. As we worked up his anemia, we came across his elevated ferritin, which kind of led us down the rabbit hole of HLH. You can see his H score there on the right. He had a very high likelihood of having HLH. Imaging-wise, we got lots of images of him, but the most notable ones were the MRI brain, which highlighted mild, diffuse, bilateral, smooth pachymeningeal thickening and enhancement, as well as trace interventricular hemorrhage. And as this was repeated about a week later, it showed similar findings. Here's his MRI, and I have a little video of it. And as mentioned, so this was a flare post-contrast series that the radiologist had noted this was the most prominent series, and he reported diffuse bilateral small pachymeningeal thickening and hyperenhancement. Tissue studies that we obtained, so a lumbar puncture was done at the prior hospital, which was hemorrhagic, and then we did 2 more LPs at our hospital as well. Again, millions of red cells, but no malignant cells were found. A bone marrow biopsy was obtained, and this showed large B cells in a sinusoidal and interstitial pattern, and then eventually we also did a dural biopsy, which also showed large atypical B cells. However, these were mostly found within the blood vessels of the dura. So his hospital course. Prior to transfer to our facility, he'd had the original MRI, which showed the meningeal enhancement, as well as that first hemorrhagic LP. We did 2 more LPs at our hospital, again, hemorrhagic, and then on hospital day 5, we repeated the MRI, which showed the pachymeningeal enhancement. We had waited a little bit because we wondered if the hemorrhagic LPs were contributing to enhancement seen on imaging. Hospital day 6, we did the bone marrow biopsy. That same day, we started Solu-Medrol to treat empirically for HLH versus what we believe to be idiopathic hypertrophic pachymeningitis. Hospital day 10, unfortunately, the patient transferred to ICU with an acidosis that was unexplained. Hospital day 12, we got his bone marrow biopsy results back showing the B-cell lymphoma. Hospital day 14, dural biopsy performed. And then hospital day 15, unfortunately, the patient passed away due to complications of the critical illness that he was experiencing. So a little bit about intravascular B-cell lymphoma. It is a subtype of B-cell lymphoma. The neoplastic growth mostly occurs within the walls of very small blood vessels. It's very rare. It does not always involve the CNS, just about 30 to 40% of the time. And the clinical picture is fairly nonspecific. Neurologic findings, B symptoms, maybe some skin findings that resemble vasculitis. What threw us off was that the most recognized neuroimaging patterns are often more things like an infarct-like lesion, nonspecific white matter, or a mass-like lesion. So our thought process is a couple things that tripped us up. We had waited on repeating the MRI, like I said, because we believed what we thought were traumatic LPs to be influencing the imaging. We also were very initially anchored on the infectious etiology and spent a lot of time working that up. And again, it wasn't until we got those iron studies which showed the elevated ferritin that we even went down the HLH rabbit hole. When we were concerned for HLH, it was confusing what might be the trigger. Was it immunosuppression from the steroids, or was this new possible cancer the trigger for the HLH? Finally, the most confusing question, was the pachymeningeal enhancement seen on neuroimaging related to the bone marrow biopsy, or did we have two separate processes? Therefore, we felt that we could not move forward with treatment for the B-cell lymphoma until we had a dural biopsy to correlate the neuroimaging findings with the biopsy results. Lessons learned, again, thrown off by the MRI findings, which did not seem to correlate with the bone marrow biopsy, and we felt we could not move forward without the dural biopsy. This obviously led to some amount of delay in care. So another lesson learned, CNS lymphoma remains an incredibly elusive clinical picture, should remain at least on the periphery of differentials when appropriate, and pachymeningeal enhancement can correlate with intravascular B-cell lymphoma, and this seems to be a novel finding. That's all I have. Thank you so much for your time and for having me tonight, and I'm happy to take questions at this time. Thank you.